We are here. I have been so excited for this chat, this very important discussion, and absolutely delighted with our incredible guest this evening. So, Dr. Sandra, thank you so much for agreeing to have this little chat with us all today and sharing some really, really important information. How are you?
I'm okay, thank you. I'm so sorry about this whole palaver. I actually learned how to get onto Zoom in a very convoluted way now.
Well, hey, listen, we all started in lockdown and we're all still learning. Very often I find myself muted and I'm chatting away. So, yeah, we still have to pick up these bits. But we're here now, which is the most important thing. So I'm really looking forward to this chat. And I think that the best way to really start this would be for an amazing introduction, really, of yourself and also your experiences and why you're so passionate about helping women, particularly with perimenopause and the menopause then.
Well, that's why I want to do more of these chats, because when we were looking through the questions that came, I found that a lot of people are actually asking, how do I know I am in perimenopause? Because it is actually a very difficult thing to know. And I didn't know when it was my time. And I wanted people to actually be able to look out for the signs. So I'm 48 now. My menopause actually started around the age of 38. Around that time, I still didn't think about menopause. And the first thing that hit me was that I started to become very sensitive. You know, I'm normally a pretty strong person, but then I get upset easily, I get irritable easily. But that actually was around the time where things were very difficult in my job as well. So I just thought, like, okay, I'm stressed. And then I started to forget everything. Like, I can't remember the names of my staff. I can't remember when somebody come into my room and start talking. I have to try and locate them in, like, okay, so they are here. They don't sound like a manager. So they're not the manager. So which part of the admin stuff do they fit in? So I had to try really hard to know. And I seen neurologists. Nobody actually got the diagnosis. And around that time, brain fog wasn't exactly very popular either. So nobody think about it. And then I got really bad pains all over. So that again, I ended up taking like an ibuprofen every day. So all of that was happening. And it took about like another, I did have an incontinence as well. So it took about like another 5 years to finally arrive to think like, okay, that's menopause.
Yeah.
So I lost about like 5 years. And then when we thought about it is menopause, I was like every other woman. You don't want to be taking hormones. You don't want to be doing anything unless you really, really have to. You want to try and soldier it out and all that. So I didn't sleep for like 3 years again. And only when I broke my hand, I got a DEXA scan, and we found that I got osteoporosis.
Yeah.
So that's only when we decided like, oh, I need a HRT.
Yeah.
So I don't want people to have to wait for like another 10 years. And I want people to be able to recognize these symptoms earlier. And the other thing is menopause is very individual situation. And you have to explain it pretty well to a doctor to understand what you're going through, and the kind of treatments that you can have also vary.
Yeah.
So you need to individualize it, and it takes some time. In the NHS, my general practice, the most time I get is about 15 minutes for each patient. So if people know what they are actually suffering and what they think it is and what they want out of a consultation, I want people to have this sort of knowledge to equip themselves with.
Yeah.
That's what I want to do.
Yeah, brilliant. And it's so important that, women know to where to get the help, to be proactive and get the help, and also what signs they may be needing to look out for. So, I mean, you mentioned there that you were experiencing symptoms at the age of 38, and I know that perimenopause obviously does kind of present itself a lot earlier than I think a lot of women think, because I think you hear that, or menopause 50, 51 average age, but not knowing that for many years prior to actual menopause, there's a whole lot of change, learning, and things to be doing. So what would you say are the first signs of perimenopause that women should be looking out for?
Well, I don't think in real life that these signs or symptoms come like this is the first one, this is the second one kind of thing. And it might vary among the individuals. And when your periods start to become irregular, you do think about it.
Yeah.
But other little things like mood changes, you may get upset easily, you may get sensitive easily and get very irritable easily. Those sort of things you might not think it is related. And the other thing I suffered was like the aches and pains. It's very, very painful, very, very stiff. You can't get out of the bed in the morning. Tiredness. You used to be a very energetic person, but you become very tired lately. So these little signs, which you don't normally suffer from, once you start getting these things, you should pay attention to them. And one of the questions that the girls submitted, they said, how do you know it is perimenopause? How do you know it is not something else? Well, you don't actually. That's why you need to go and speak to somebody, usually your GP, and explain to them as in like, I'm very tired, I got aches and pains, or I'm being like really sensitive to literally anything. I cry easily, I get irritable easily, I seem to be forgetting things. What could it be? If you think it could be perimenopause, say it.
Yeah.
And what the doctors would normally do is that they will try and exclude other things. Like if you're tired, I would think like, okay, could you be anemic? I might be checking bloods. There are other causes of tiredness, like your thyroid problems, diabetes, these sort of things. We'll check them all first. And if somebody's periods are irregular, we'll try and delve a little bit deeply into your usual period pattern and what could be causing this. Perimenopause is more of a diagnosis of exclusion. You need to try and exclude other things first, because those other things you can correct them.
Yeah, of course.
And once you've actually corrected all of them, you need to start thinking like, okay, this could be perimenopause. The other important thing about perimenopause is that you are still fertile around that time. So if you are in proper menopause, if you're not having any period at all, you could just take HRT and be done with it. But around the perimenopause time, you want an HRT that has got a contraception incorporated in it, or you want to try HRT on top of a contraception. So that sort of thing you want to try.
Yeah, of course. And it's very interesting about that contraception part then, and some of the girls have asked as well about the Mirena coil, because that gets mentioned a lot. Why does that get kind of recommended for women then?
Well, the Mirena coil has got the use in both ways. You could use a Mirena coil for contraception, and you can use the Mirena coil as the progestogen part of your hormone replacement therapy. So now that we actually moved on to the hormone replacement therapy, shall we just start talking about it then? So what happened is, around the perimenopause time, your ovaries they start to become a bit lazy, or they're coming up to pretty much up to the end of date. So they don't produce the hormones that they normally produce as much as they normally produce. And we normally produce 3 hormones. One's estrogen, the other one is progesterone, and the other one is testosterone. People tend to think that testosterone is a male hormone. It's not that is not the male hormone. Yes, they do have it, But again, they produce these three hormones as well. It's just that in women, estrogen is more of the dominant one, and in men, testosterone is the dominant one. But when your estrogen, progesterone, testosterone, when all of them go down, that is around the perimenopause.
Yeah.
But the thing about perimenopause is you can't really do blood tests because the level doesn't stay at the same level. So you could be, at one point, they can all be low. And then some point, one of them could be high, one of them is low. So it's really no point in checking blood tests for perimenopause.
Ah, interesting. Okay.
Yeah, because it really doesn't stay the same. You
Yeah.
could have one result now, and then you could be having totally different result in a few months' time. And when do we check bloods is usually if it is under the age of 40. Anybody over the age of 40, and if you are having symptoms of menopause, perimenopause, you don't necessarily need a blood test. So the estrogen, when it goes down, you start to feel like hair thins, your skin's a bit dry, your zest of life or your like a joie de vivre is gone, and flushes, sensitivity to hot. A lot of people know about that, but sensitivity to being cold is something else people don't think about. A person in that menopause, perimenopause could be like hot and cold, different times all the time. Progesterone is important in maintaining the lining of your uterus. If you give somebody estrogen only, and if you don't give them the progesterone, that estrogen is going to make the lining of the uterus really thick. A thickened lining of the uterus, first of all, can give you a heavy bleed, and it can actually change into cancer. So we don't want that. That's why when a woman has got a uterus, you can't just give them estrogen. You have to give them progesterone as well.
Right. Yeah.
Testosterone mainly is concerned with the libido. So if you got like no interest in libido, you got problems with the relationship, we usually start giving people estrogen first, because unless you got enough estrogen, the extra testosterone we give doesn't really work much anyway. So you start with the estrogen. If that is still not helping with your libido problem, you give testosterone on top of that. But that's what the NICE guideline says. But in reality, the testosterone is pretty good for memory as well. So people with brain fog, they're pretty good for that. And aches and pains, that's really good for that. And the energy levels, the tiredness as well, testosterone really good for that.
Yeah.
So there are three hormones. We really should be thinking about replacing three hormones. But if you don't have a uterus, you could just think about estrogen. You don't need a progesterone. But if you do have a uterus, you need a progesterone. And Marina would actually do the job of both the contraception and protecting your uterus.
Yeah.
So with the Marina Coilin, you probably have either a lighter period or you don't have a period. You don't have to worry about thicken and lining of your uterus because it just doesn't thicken up anymore.
Yeah.
It's in there and it's fried the inside of it. So you don't have to worry about it. So if you can tolerate it, it's a really good method. It lasts for 5 years. And for menopause purposes, you can use up to about like 7 years or at the age of 55. So that's really good. And the other type of progesterone we got, the type that is identical to what our body produces, called utrogestin. Utrogestin is a micronized progesterone. So it's exactly the same as your body progesterone. So that has got less of the side effects. Side effects of the progesterone are mainly bloating, and some people feel gassy, some people feel a bit constipated. So a lot of people worry about taking the progesterone by mouth. So if you take the progesterone by the uterus way, which is the Marina way, you might bypass that problem.
Right. Yeah.
So yes, so Marina, a good one, especially for the perimenopause. If you can't have a Marina, or if you're too afraid to have something that way, You could think about the utrogestin. Utrogestin, you can have it by mouth, or you can actually use it vaginally as well.
Yeah.
And there is another new tablet called Baiju. Baiju has got the micronized progesterone and the body identical estrogen in it. So it is a good one as well.
Oh, brilliant. It shows that it's not straightforward at all when, you know, looking at helping women the best that they can. And I think that a lot of the girls watching and listening with this right now kind of feel that as well through their experiences with HRT. You mentioned about, you know, the reasons why we have to have the progesterone and mentioning cancer. And I think that that has been one big worry for a lot of women as they think, oh, I'm not going to go on to HRT because of this risk. So I suppose really, could you clarify, you know, clearly the benefits of HRT, the risks, and also how would girls work out that they're taking the right one, that they're getting the right dose, and how long should they be waiting for it to be kicking in for them?
First of all, the advantages of HRT. There was another question I saw that someone was asking, how much percentage of women go through HRT, go through menopause without HRT?
Yeah.
Well, you can't really say because 100% of women will go through menopause.
Yeah.
And some women will take HRT because they actually know the benefits of it. Some women will take HRT, but they might consider it as a defeat. They might consider it like, well, I couldn't do it without HRT, so I had to go on HRT. So that percentage doesn't really matter. What actually matters is, why would you take an HRT and why wouldn't you take an HRT? So why would you take it? There is a perfect time to take the HRT. Like I missed that perfect time. I missed that first 10 years. The first 10 years of the menopause, perimenopause, is the time that you might want to replace your hormones. Because women are actually protected by estrogen from a lot of things. Our risk of having a heart attack is half of a man when we were still producing estrogen. The minute your ovaries stop producing that, your risk suddenly become double and you become equal to the risk of men. Another thing is your bones. The bones are actually protected by estrogen. And once you suddenly lose that protection, your bones become very brittle. So for a tiny little fall, I basically broke all the bones here. And if I had been taking the HRT in the last 10 years, that probably wouldn't have happened.
Yeah.
So there are some benefit in replacing your hormones, and it's got to be time specific as well. So for any woman who is in the first 10 years of menopause, replacing your hormones should have a lot of benefit on you. Yeah. After those first 10 years though, if you didn't take it in the first 10 years, and then now you decide like, okay, I can't cope with these symptoms anymore, I'm going to take it. You will still have the benefit from the symptoms point of view. But any other benefit that you might have from protecting your arteries, protecting you from a heart attack, or protecting your bones from becoming brittle, all of those effects are a lot less. So you need to know why you are taking the HRT when you are taking the HRT. If you're taking the HRT in the beginning of a menopause, you would have not only the symptom control benefit, you're going to have the benefit of protecting your bones, protecting your heart, and you also have some benefit in your memory as well. After the 10 year though, I would usually advise based on the symptoms. If the woman is suffering these symptoms of can't sleep, too hot, too cold, emotional, aches and pains, all sorts of symptoms, I might still recommend the HRT, but I wouldn't want them to take it as a prevention purpose of it. The risk, the uterus cancer risk is actually pretty low, because if you do have a uterus, your doctors will give you progesterone to protect the uterus, and we're done. Only if somebody has got a uterus and they're only using their estrogen and not using the progesterone, that's when they will risk having a risk of having the thickened lining of the uterus. It does happen though, because even though your doctors are telling you that you need the two hormones, out of the two, estrogen actually make you feel good. The progesterone, on the other hand, doesn't.
Yeah.
It actually makes you feel a bit bloated and it makes you feel a bit gassy. So people don't want to take it. But if that happens, do speak to your doctors, because you can change the type of the progesterone. You can find a different one, or you can find a different route. You will find something that agrees with you. Because I was sensitive to progesterone. I was very sensitive to it. Even when I was taking a contraceptive pill for my skin, I had to find a type that agrees with me. Finally, I found a type that doesn't have any progesterone in it. That's the only one that agrees with me.
Yeah.
And then when I tried to take the HRT, I couldn't take the Utrogestin at all. And I couldn't do Marina Coil either because my cervix was too small. So I couldn't do that either. And then I tried Baidu, and the progesterone in Baidu should be same as the Utrogestin, but the way they made it might be a little bit different because I could tolerate the Baidu. So just because you don't tolerate one progesterone, don't think that you're not going to tolerate all of it. If you do have a uterus, you need a progesterone, do find one that would go with you. If you don't have a uterus, fine, you can just do the estrogen and you're okay. So let's talk about the risks. Another risk that people are actually very concerned is the breast cancer. So breast cancer is very common in women. Just by being a woman, you are at a pretty high risk of breast cancer anyway. So if you look at 1,000, 19 will develop a breast cancer, with or without HRT, with or without a family history, whatever. Out of 1,000 women, 19 are going to have it anyway. But if you are on an HRT with the estrogen progesterone, you can have like 4 extra cases. So that 19 would become a 23.
Right.
But that is for 2 hormones, estrogen and progesterone. If you don't need the progesterone, and if you are the person who doesn't have a uterus, and if you're only taking the estrogen, it actually reduces the risk. The 19 would actually become about like a 50. So the HRT isn't exactly the bad guy here. The HRT can increase the risk a little bit. And I just noticed there was a comment there that I had a breast cancer a few years ago. And there was somebody who talked about the breast lump as well. For women who has already got a breast cancer, or who has the experience of a breast lump, etc., you do need to speak to your doctor in your individual circumstances, depending on the type of the breast cancer you had, depending on the treatment that you had or the treatment that you're still having, or the duration, how long ago was it? All of that needs to be taken into consideration. Your doctor and your breast doctor can talk and try and find something for you. Not everybody can have HRT, but a lot of people can. And those people who cannot have HRT still can do other things.
Yeah.
There are other things. But let me continue about the breast cancer risk. So we are talking about estrogen, progesterone. Estrogen, progesterone together, HRT might give you 4 extra cases. Estrogen alone actually reduce the risk. And if you exercise, you might actually reduce the risk a whole lot less. If you drink alcohol, you increase the risk a lot more than the HRT might have increased your risk of breast cancer. So some women might be so afraid to take the HRT because they're worried about the breast cancer risk, but they may still be smoking and drinking alcohol. That actually increase your risk of breast cancer a lot more.
Yeah.
So that's why lifestyle is pretty important when you come into perimenopause, menopause. Somebody said, "What can we talk about lifestyle measures in menopause?" People might not like it very much, but you can drink very, very little alcohol.
Yeah.
A normal safe level of alcohol for a woman, 2 units a week. You have to half it when you come into perimenopause, menopause.
Wow.
Because, yeah, because menopause is actually aggravated by alcohol. Caffeine aggravate that. So the symptoms actually get worse.
Yeah.
And like I said, the alcohol and smoking will increase your risk of breast cancer more than HRT will do. So if you are really worried about all these problems, you really should cut them.
Yeah.
And again, after menopause, your risk of heart attack already increased. If you drink or if you smoke, your risk is going to be a whole lot higher. That's why women will have a lot more heart attacks after menopause than men. So a very good lifestyle, really important. Exercise though, if you exercise half an hour a day for 5 days a week, you would actually reduce that risk of breast cancer by like 7. So that's really good.
Yeah.
That's why lifestyle is really important. And that exercise that you do should be more of a weight bearing kind of exercise. So it should be something that you do by standing. Swimming's really good, but it's not exactly weight bearing. So if you like doing it in water, do like aqua aerobic.
Yeah.
So that's the lifestyle thing. And what else have we got? Oh, how do you know that you're on the right HRT?
Yeah.
It's very individual situation, and it's not really HRT's fault, or it's not really the fault of the person who prescribed it for you either. It's just how your body is made of and how these drugs are made of. And then you have to find the right one that actually clicks with you. In general rule, any kind of hormone, it would take about 3 months to get used to your body.
Right.
So I would always say to my ladies, give it 3 months at least. In 3 months' time, you will eventually know that this is working somehow. So like if you are a perimenopause or menopausal woman starting to take an HRT, usually the first thing you notice are like hot flushes or cold sensitivity, sleep. Those things get better quite quickly within the first few weeks. And then the joint aches and pain, muscle aches and pains might get better around like a month or so. And then after that, like in the 2-3 months time, you might start noticing like your energy levels are back, your memory is not as bad as it was. So it actually takes about like 3 months for all the whole round to get better. So we usually see patients in about like 3 months and ask them, well, what bits do you find are useful? In the first 3 months, you might get a bit of a bleeding irregularity as well. So we accept that for 3 months. If it continues within 3 to 6 months, so we might start investigating.
Yeah.
So HRT can be very useful. It can be done safely, but you just need to do it closely with a doctor who can advise you properly then.
Yeah. Yeah.
But don't get upset just because you have to change it like 2-3 times. It does happen. Even if you were settled with one, your body may have changed, so you might have to change it again. It's just a fact of life that we have to deal with, because we if we don't replace the hormone, you don't have to do anything. But if you do replace the hormone, you'll have to find a medium which is totally perfect just for you.
Yeah, we're all very unique, and that's what makes us all so wonderful, which is important to remember. I know the time is going on, so there are two questions that I'd like to ask as well. One is there have been some incidences where people, women haven't been able to get maybe their prescription, it hasn't been available. So in a situation like that, what would you recommend? Would changing and going for something more readily available be an option? What would you suggest in a situation like that?
HRT is very notorious in being out of stock.
Yeah.
And usually when you have one stock, a lot of women have to change into whatever is available. And then that stock become unavailable. And then you have to change it all over again.
Oh,
so yes, you do have to change it, because otherwise you'll be without anything.
Yeah.
the hormone replacement is not something that lasts in your body very long. It does last for about like a month or so if you have been using it for about like 6 months. But if you haven't been using it for very long, and then if you are out of drug completely, your symptoms will come back. One of the questions with that, somebody said, what after HRT? When you stop the HRT, would the symptoms come? Would it just delay it? Well, you don't have the symptoms because you are replacing the hormone. So yes, you do have the symptom if you stop replacing the hormone.
Yeah.
But then if you do, I would ask the ladies to do it a bit slowly so that your body get a bit used to having it little and little. And by the time you get nothing, your body is actually quite good with coping it. So that's how you would do it. How long you take the HRT, you can take it as long as you need it. The British Menopause Society, NICE, all of them said that you should not put some arbitrary deadline on it.
Okay.
You can be on it as long as you need it. But yes, if you go to the chemist and if the chemist tell you that, oh, I don't have this, you might want to go to a different chemist and look for it. Because usually if you find a good one for you, you don't want to change it. But if not, though, ask the chemist, well, what have you got similar?
Yeah.
Write it down for me, and then you can take it back to your doctor. Because otherwise, there are so many different kinds, and the doctors wouldn't know what is actually available.
Yeah.
So you need to know what is there actually available, and then your doctor can look at these and see, like, okay, so this one is pretty similar to what I wanted you to take. So we'll go for this one.
Brilliant. That's really good to know. And also, and this has come up twice as well, antidepressants being used to help out with maybe perimenopause. And also, how would you know the main difference between perimenopause and depression to know which is most likely, as the symptoms are quite similar then?
As doctors, though, we are trained to know, like, if somebody's anxiety depression is more hormonal or something else we call endogenous. Endogenous depression makes somebody like very depressed all the time. They can be like self-harming, suicidal, the sort of things. With the hormone imbalance people, though, they may have a history that they tend to be a bit emotional, or they tend to have mood swings when their hormones go up and down at the time when they were still having the periods. And the fluctuation is a bit more noticeable. So when we get a lady coming in and talking to you, that's the kind of symptoms that we try to get out of the patient. Is it all the time? Or are you finding that this is very fluctuational and you go from 1 minute to the other in these extremes very, very quickly, kind of thing? And a very depressed person who is suicidal or self-harming, etc., may actually need an antidepressant. They may need the HRT as well, but they might not cope just with the HRT. But on the other hand, the guidelines have said that if a woman is suffering hormone-related mood changes, you shouldn't just go around giving them the antidepressants, because that's hormone replacement therapy is what they need. So your doctor should be able to differentiate between the two if you give them a proper history. So that's another thing that one of the girls has asked, how do you get the most out of your doctor consultation? It's mainly preparation. And then you summarize your symptoms pretty well. And the doctors are actually trained to get the idea, concerns, and expectations out of a patient. So if you have an idea what is wrong with you, you can say it. If it is totally wrong, they'll tell you, well, I don't think it is the thing because of this. If it is something relevant, they say, well, yeah, that's a possibility. What are you concerned about? You may think that you are in menopause, perimenopause, but you are a bit concerned about HRT because there is a lot of bad reputation around it. And what do you expect after this consultation? Do you want the doctor to give you an HRT, or do you want the doctor to just investigate you about your symptoms? So if you can communicate clearly, you're going to get the most out of that consultation.
Yeah, excellent. That's brilliant to know. Thank you. I'm going to ask two more questions, and then we'll. There's been so much already, and let you go free. So, but here, when my symptoms returned and I was told to increase the dose, I found I started bleeding as if having a full period again, along with all of the pain, etc., that goes with it. Does that mean I took too much, or was the period a sign it was the same balance as before the menopause?
Like I said, any HRT, either in the beginning of you taking it or change in the dose, in the first 3 months, you can have a bleed.
Yeah.
So that is actually quite expected. So I wouldn't worry too much about it. Whether you are on the right dose or not, you can't decide with the bleeding. You can only decide with your symptoms. So that's basically it. You could do blood tests, but the blood test doesn't really tell whether you are on the right dose of estrogen or not either. We usually go by a balance between the symptoms and the blood level, maybe, because sometimes we have got some patients who kept on increasing the dose, and then there is a point where you get a bit worried, so you do blood tests. And then you can actually show the patient that we don't need to keep increasing your dose. Your estrogen level is pretty much through the roof.
Yeah.
We need to find out why you are having these symptoms.
Yeah, excellent, lovely, thank you. And this last one, and this will bring us on to us kind of wrapping up the show, which will flow quite nicely. Clearly, there is a lot more awareness and knowledge out there now than even a few years ago. But do you feel that doctors are far more aware and trained and knowledgeable now, or is there still a way to go? And is there any directives such as each GP practice needs someone who specializes? Because obviously, we are so lucky to chat with you, and you do specialize in this, but what are your thoughts on those questions there?
I was on the task force organized by the Welsh government. So we did have recommendations after the task force has finished all the meetings. And each GP practice to have somebody who specializes in it may be a bit difficult to do, because it actually is a pretty big subject. And somebody specialize in it that does need to finish quite a few courses about it, and you need to do a pretty long training, logbooks and all that. So the health boards should be able to offer a community type of clinic where women can be referred to from the GPs if anything is beyond simple. All the GPs are actually trained to be able to recognize menopause and give simple starting HRT treatment. But anything that needs tweaking, or anybody who is a bit difficult in finding the best course for them, etc., or patients who had some kind of cancer in the past, those people should be referred to those community menopause clinics. That is one of the requirements that the government definitely want to do. And then these clinics would liaise with the secondary care specialists. So that is the idea. It is happening. It will happen soon.
Oh, that's great to know. And what will be very great for everybody to know is that you do offer clinics. So how can any of the ladies that are listening now, how can they reach out to you? How can they maybe invest in having your support?
Well, the easiest way that doesn't cost you anything is the website that I made. I made that website so that I can direct people to go on and look at the resources. So the website, I think you have got it right. You can give it out to the girls. My name is Dr. S. Line Women Health. And if you go onto that page which says resources, it is not just about menopause. It's quite a few things that women would find useful. So it's like menopause, HRT, but you have other things like diet, mental health, lifestyle. So start browsing through it. I put in different kind of resources, as in like websites or videos, podcasts, books, whatever is your strength, whatever way you like to read more about things, you can do it there. I do. I work for the NHS in the SA1 in Swansea. I also do the private practice for Santa Maria in Swansea, and there is a group called Independent GPs. So for them, I do remote consultation. So that basically people all over the country can join that remote consultation. They can book through IGP, and I also do a clinic for IGP where I can put Menopause in. So that's another thing. And there's a clinic called 1192 in Swansea, which I do Saturday mornings. So depending on your availability and stuff, you can do it. The thing about private practice is that the thing I like about private practice is I can actually give more time.
Yeah.
In the NHS, I'm actually fighting for time, but I don't really want people to be actually spending money for it. That's why I do these sort of talks. So if you know more about it, if you know what to look for, if you know how to get to the doctor and what to ask, you might not need those. You may just be able to do that with your doctors, and you'll be fine. So yeah, have a little bit more read about it, and we could do these sort of talks in different kind of topics like menopause and mental health, or menopause and osteoporosis, menopause and lifestyle, that sort of thing, because today is like a bit too broad.
Course. Yeah, absolutely. If we can have the chance to do, lots of different chapters of this, big subject, that would be absolutely incredible. And, chatting about this tonight, it is so empowering and amazing for everybody to get some more information this evening so that they can go and see their GPs. And then also, if they do want to have, a little bit longer time and invest in, the private service, they're obviously knowing that is an option as well. So absolutely amazing. Thank you so much for taking the time to chat with us all this evening. I'm hoping I can take a quick picture of us so we can put this on the group for everybody as well. Amazing. I am delighted that you've taken the time to chat with us tonight. Thank you so much. I absolutely loved it.
Thank you for having me.
Thank you so much. I'm going to